I'll be talking about a Keratoscope which we've designed for intraoperative use, which can be used live during surgery to regulate postoperative astigmatism. So if we look at the background of keratoplasty, this is the picture from 1906 when Dr. Edward Zern, he started, he did the first keratoplasty, and if you see the picture, there is no microscope, no fancy equipment, nothing. And that is how it all began. He used just a basic trephine, a few needles, and that was it. That was how the keratoplasty journey began. And over the last 1 century, we've come a long way. A lot of fancy equipment, fancy stuff. We have immunosuppressions. Then we have fancy microscope, eye banking, trephines, all sorts of things. Yet, if you look at the keratoplasty outcomes, one facet of the outcome is graft survival. So we've reached as far as 90%, wherein we are able to take care of almost all the grafts that we implant. But if you look at the visual outcome, there are articles which report all the way up to 15 to 20 diopters of astigmatism post-operatively, post-keratoplasty. In such a situation, obviously the patient is going to have a functional outcome, anatomical outcome, but not a functional outcome. So these are many such articles discussing how to prevent astigmatism, how does it occur, what are the different suturing techniques, what all we could go for, all sorts of things. The debate has been raging on since decades. Look at this picture. This patient, a fantastic keratoplasty, fantastic looking sutures. The natural lens, crystalline lens also has been maintained, but the astigmatism is 8 diopters. Obviously the patient is going to have an extremely bad vision. So what we thought was that we need to create something which could help us manage the astigmatism intraoperatively. So in that context we thought of a ring which will be reflected on the cornea. So usually we take a graft about 7.5 mm. So we would need a 4 mm diopter ring which will be reflected off the graft surface. The concept, the product has to be new, inexpensive, simple, replicable. And for that we went back to the Bosch and Lomb keratometer formula, wherein if you just look at the formula, R is the radius of curvature of the cornea, and which is the graft. Second is the working distance of the microscope, which is usually 200 mm. The image size that we needed was 4 mm. The size of the ring that we needed is what we needed to find out. Through all the calculations using the Bosch and Lomb keratometer formula, we were able to deduce that we need a 21.3 mm diameter ring, which will be placed at the objective level of the microscope. We got this LED light flexible thing for just about $200 from Amazon, and this is how it looks. So this was placed underneath the microscope at the level of the objective. The distance of this ring to the eye, to the cornea, was what we calculated. That is how we were able to deduce the diameter of this ring. This is how it looks when you look at it from the patient's point of view from underneath, and this is how the working system happens. And you can see surgery being done, sutures being placed. And if you switch off the light, this is just for demonstration how the ring looks. You can also see the ring with the illumination on. And while suturing, you could manipulate the sutures in a manner such that you get a nice round circular ring at the end of your sutures and during your suturing as well. Obviously, those of us who do keratoplasty, we know that the first 4, the next 4, the first 8 sutures are what will determine the primary astigmatism of your graft. This is another picture, this is another video wherein a femto-DALK keratoplasty was being done. And this is the graft being placed and sutures being placed. Initially you see that the ring, the reflection, the Myers are not very round or regular. As in how the sutures are being manipulated, the Myers start getting rounder, circular. And this is how you'll know. And in case, suppose you have a oblongish oval extension of a Meyer in a particular direct axis, you will probably need to tighten that suture. So coming back to the video that we just saw, this is the post-operative astigmatism 1.2 diopters, fantastic outcome. Another video, this is just the end wherein the sutures are being, this is a continuous suture being manipulated such that you, I'll just show you the, just a second. So at this point, if you see, you have a nice round circular mire. This is what gives you some assurance that this patient is going to have a reasonable amount of astigmatism. And this is what is the outcome, about 0.9 diopters, 1 diopter of astigmatism. So what we did was we made two groups, group A, group B, 50 eyes in each group. One group underwent keratoplasty with the use of this intraoperative keratoscope. The other group just underwent a regular keratoplasty. Three parameters were checked. One is mean refractive astigmatism, mean topographic astigmatism, and the post-operative vision. So if you look at group A, which was the Keratoscope group, so mean refractive astigmatism was 1.38, mean topographic astigmatism was 2.46, and to our what we had expected, the group B, the non-keratoscope group, had 4.4 diopters and 5 diopters of astigmatism on topography as well as refractive astigmatism. Then the uncorrected and the best corrected vision obviously was better in the group A, which underwent the use of keratoscope, wherein obviously since the mean astigmatism was much lower, the uncorrected and the best corrected vision was much better. So what we say is that the keratoscope is a simple, cost-effective, replicable device which can be placed for any microscope, it can be used anywhere. Most of the devices that we have currently will not be able to give you the simple devices which will not give you live, real-time ability to manipulate sutures. In the sense, you'll have to place your suture, then you'll have to check the mire, then you'll have to put the mire aside, you'll have to again control your sutures that way. This will give you real-time ability to control your sutures. This is another interesting case. This is a post-keratoplasty case. Patient came 7 years after the surgery, almost 13 diopters of astigmatism. This is how the mires look before the intervention. You can see it's completely oval. This is the graft. The graft is in situ. All of us who've been doing keratoplasty, we know that the graft can just be separated by a Sinski. And it was just separated, not removed, and sutures were replaced. And, okay, this is looping, the video is looping again. So in the end of the video, you can see that the mires have regularized, and I'll show you the patients. See, this is how the mires have regularized at the end of the surgery. And the ultimate astigmatism was 3.6 diopters. Much better than the 13 diopters what the patient had earlier. This 3.6 diopters can be corrected in many other ways subsequently. So this is our team. The original concept was by Dr. J.K. Reddy, and this is the entire team who's been working on this. Thank you. Any questions?
So actually what I can think of is, because what is little bit missing there is the fact that it's subjective again to see the ring, when you're trying to make out if it's ovalized or it's centralized. But if you have an intraoperative guidance system, say like a Varion or a Callisto, you can actually put that Rexis marking and choose it to your right sizing of that ring and overlap it to see if you are actually becoming more circular or not.
Correct, true. So that is what, that is not available at most places, at most centers. So we were looking at something that is cost effective, and this could in fact even help students or trainees especially. And many of the post high astigmatism that we see are usually done by surgeons with a lesser experience. So, and those people are very likely to not have access to fancy equipment.
No, just thinking out loud, you can use image guidance with your, and how big is it? Is it difficult to mount on the microscope?
No, it's very easy. What we would really need is to find out the working distance and just put it in that formula. So suppose the working distance for your microscope is, let's say, 150 for example. Then we'll find out the diameter. Just it can be plugged into any microscope at the objective level and it should go. That's
Excellent.
it. Fine.
So I now